Thank you, Sue, for the introduction. And today I'll be talking about quality improvement in BMT practice. Healthcare is changing rapidly, and it's important to focus on continuous quality improvement in our everyday practice. FACT guidelines discuss the need for quality improvement and quality management in our BMT programs. So first I'm going to talk about 5 quality improvement projects that we've done at Dana-Farber, and then we'll have a discussion about QI projects that other institutions are doing. First, I just wanted to highlight a paper that Deb Yolen-Rowley presented last year. The purpose of this study was to assess the quality of AML care provided by a physician assistant service compared with a traditional model. I'd like to mention that Deb co-first authored the paper with Dr. Brett Glotzbecker. Having a physician champion for quality improvement projects is very important. Dr. Glotzbecker and other physician champions serve in a leadership capacity, promoting, helping to implement QI work, and providing support. This slide shows that there were no differences in the demographics of patients, and neither cohort was sicker than the other. There were a total of 95 patients, 47 patients on the house staff service, and 48 patients on the physician assistant service. The median age was 52, and the sex ratio was similar. The number of patients undergoing a previous bone marrow transplant was also similar, and the baseline labs to measure acuity on admission was similar and included white blood count, LDH, platelets, uric acid, creatinine, presence of DIC, and fevers. So as you can see, most of these were similar, and there was really no difference in the patient characteristics. The primary outcome, length of stay, was significant, favoring a lower length of stay on the physician assistant service. There was also a significant difference in the readmission rate and the consults requested. Typically, there's an inverse relation between length of stay and readmissions, but this study found that they were both lower on the physician assistant service. And in conclusion, the PA service was associated with an increased operational efficiency, decreased length of stay, and readmissions without compromising inpatient survival. Next, I'd like to move on to the quality improvement projects that we're doing at Dana-Farber. In 2010, the Partners Clinical Process Improvement Leadership Program was developed. It was designed to address the unique challenges and leverage the strengths of our system. The goals are to identify gaps in quality and efficiency of care, to apply process improvement skills as a means to reduce unwarranted variation in clinical processes, to apply skills of primary data collection, analysis, and interpretation to understand and improve clinical processes, and to develop leadership and communication skills required to assemble, manage, and function within interdisciplinary teams in order to solve clinical process challenges. So some of these projects were actually done on non-BMT services, but they can be applied to a BMT service. The first project was to improve the percentage of discharges signed before 11 a.m. on the Oncology F service. Prior to the intervention, 13% of discharges were signed prior to 11 a.m. We proposed to increase the percentage of discharges to 25%. So these green lines show when the interventions were made, and then the improvement in the percentages of discharges signed follows that. The interventions that were done were implementing a new lab form to eliminate AM lab draws on the day of discharge in order to facilitate early discharges, to incorporate the form into daily rounds to identify potential discharges 24 hours in advance, and to educate PAs and hospitalists on the importance of early discharges. We exceeded our goal by 25% by an additional 17% to 42%. We also decreased lab utilization on the day of discharge from 93% to 85%. So we were able to improve discharges time before 11, but we actually were not able to make a significant impact on discharging patients out of the hospital before noon. We were able to identify confounding factors such as patients not having rides, patients needing a red blood cell or platelet transfusion, and now we're working on improving those factors. Our next project was improving the appropriate use of antibiotics in patients with febrile neutropenia. We proposed that 90% of non-BMT inpatients who develop neutropenic fevers and who are medically stable will experience appropriate use of micafungin and vancomycin. Appropriate use of micafungin was defined as not receiving mica before 96 hours after first culture for FNN. Appropriate use of vancomycin was defined as discontinuation of vanco at 48 hours in the setting of negative cultures. Interventions were creation of a laminated pocket card that summarized antimicrobial guidelines. We held educational sessions with attendings, ID attendings, house officers, and physician assistants to review antimicrobial guidelines, guiding principles of antimicrobial therapy, and how to use the card as a tool. We elicited feedback from house officers and physician assistants about the usefulness of the card and whether they encountered any resistance to following the prescribed guidelines. Following the intervention, or prior to the intervention, 58% of the time vanco and mica were used appropriately. After the intervention, they were used 88% of the time appropriately. Although we fell just short of the goal, we were able to improve a clinical process and learn through the steps and the interventions made. So that's one of the key features of the CPIP program. Even if the goal, we fall just short of the goal, we want to focus on what we learned from data collection, analysis, intervention, and recollection of data. Our next project was securing discharge follow-up appointments. We proposed that 90% of medical oncology GYN patients will be discharged from the hospital with follow-up appointments scheduled. Again, these green lines show the intervention and then the improvement seen. The interventions were creation of a scheduling template, including all required elements necessary to book a follow-up appointment. We streamlined the communication process between the discharge team and personnel responsible for coordinating follow-up care. We established a default time frame of 7 to 10 days in which all hospitalized patients would return to see their provider. From these interventions, we showed that securing a follow-up appointment prior to discharge was feasible, and we increased compliance from 49% to a sustained 84%. We're now using this form on other physician assistant services, further increasing compliance. Next, the next project was focused on minimizing the number of routine chest x-rays ordered for elective auto stem cell transplant patients on a PA service. We proposed that 90% of patients admitted for an auto stem cell transplant would not have an admission chest x-ray unless clinically indicated. Our interventions were consolidating all pre-transplant testing from outside hospitals into one label folder. We educated PAs, nocturnists, nurses, and supportive staff about the need, outcomes, and costs of routine chest x-rays. We created a folder with the project information to distribute to the nocturnists with daily pass-off. With these interventions, we reached our goal of greater than 90% of patients who did not have an admission chest x-ray without indication. The cost savings from this project was significant. In the 4 months prior to the intervention, over $24,000 had been spent on chest x-rays. In the 2 months after the intervention, about $880 was spent on chest x-rays. We have since expanded this to the allogeneic population as well. And the last project is reducing unnecessary differentials in auto BMT patients. We proposed to reduce the number of differentials ordered by the primary team during periods of neutropenia in patients undergoing an auto stem cell transplant for lymphoma and myeloma by 20%. So line here should actually, is supposed to be on the bottom, showing that 0% of differentials during periods of neutropenia were ordered appropriately. And then the red lines are the intervention. Our interventions were presenting the background data and rationale of why differentials were not necessary during the neutropenia period of an auto BMT. Buy-in from leadership and staff was obtained. As part of the intervention, we adjusted the chemo template to make it easier for PAs to discontinue the CBC with differential at the right time. Next, we presented the results to the BMT program and project team. We learned that unnecessary differentials were being sent without an order, and when staff other than PAs were covering as responding clinicians, the orders were not being changed. We continued our educational efforts with email communication and face-to-face meetings with nurse educators who developed a clinical alert and monthly meeting reminders. With these interventions, we were able to reduce unnecessary differential orders by 68%. The potential impact of this project is significant. Our approximate period of neutropenia in our patients is 9 days. A CBC with differential costs about $94, and a CBC without a differential costs $76. CBC with differential has about a 45-minute turnaround time, and a CBC with a differential has about a 240-minute turnaround time. With 4,500 differentials during the period of neutropenia in our program, we could save over $80,000 and 18,000 turnaround time hours. So in conclusion, I'd like to thank you for allowing me to share our center's QI work. Again, healthcare is changing at a rapid pace, and it's important to focus on continuous quality improvement in our everyday practice. As nurse practitioners and physician assistants, we need to show our value, the value we can bring to healthcare. To improve a system, you need a good understanding of it. And nurse practitioners and physician assistants have the institutional knowledge to really benefit a QI project. We often have a stronger affiliation with supportive staff, which is essential for QI projects. Furthermore, small initiatives add up. Our chest x-ray project saved $10,000 in just its first month. It's important for us to receive credit for our quality improvement work, and I'd again like to emphasize the importance of having a physician champion with this work. So I posted a couple questions up here. I think they're on those sheets. And then I put my contact information and Deb Yolen-Rowley's contact information if anyone has questions about QI projects. I was actually presenting these projects, but Deb has really been spearheading this work at Dana-Farber. So she'd be happy to answer any questions via email. And I'm happy to take any questions now.
Thank you very much, Colleen, for the presentation of all the QI projects and the work that you've done. I have a question in regards that I think may reflect on our own practices at home in each of our centers. When we have an idea that we want to further work on and change and make the changes happen to improve our work setting or et cetera, we sometimes have difficulty getting the clinical practice and your time at your desk where you can work on the projects to equal something that will give you that opportunity. And I was wondering if you could elaborate a little bit about the model. Like, is it a 80% clinical, 20% of your time at work for project work at your desk, away from clinical care? Can you elaborate on that a little bit? How do you secure time to work on these things? Because I think that would be really important to share.
Yeah, no, that's a great question. And these CPIP projects are about a 4-month project, and they meet monthly as a whole group. And usually we try to work into the schedule that once a week, the physician, or a couple times a month, the physician assistant would have a administrative day, so other staff would cover. So these projects, usually there's 1 or 2 physician assistants per project period. They do it twice a year. So we try to fit that in, but I think a lot of times it winds up coming out of off work time as well. So I think that's been a challenge for everybody. Anything else? Thanks. Should we try to have people get in? Okay. If people maybe want to move up or consolidate into a larger table so we can start the roundtable discussions. And I can read these questions that we'll talk about. What changes will foster the ability for staff to work at the top of their licensure with scarce resources? Describe successful models for improving workforce recruitment, retention, and work-life balances. And then list the clinical practice improvement projects that you're working at your center. And also if you've found barriers to QI work, we can talk about that too.
So I think if everyone could consolidate so that we can fill the tables and have a better discussion, that would be helpful. And maybe if we spent maybe 10 minutes on each question, the last one's not really a question, but it's more of a comment, but if we could elaborate on that. I think we have time to spend maybe 10 minutes on each one, and then have someone at your table sort of take notes. And when the 30 minutes is up, we'll go ahead and have the person, one of the people from your table, discuss what each table came up with. When this is all finished too, when we leave, I'd like to try and put things together, summarize everything that we've done here today, and then somehow get it out to the group to see what the results and findings were. I can do that through the listserv. If y'all can get on the ASBMT website and sign up for that. That's where I think we should probably start, by posting the information we gather from today.
Everyone, it's a little before noon, and I thought maybe we could start having some of the groups come up to the mic and talk about the 3 questions. I know some people need to leave a little early to make flights, so if one of the tables wants to start. Any volunteers? Okay, go ahead.
Do you want us to?
Yeah, if you just talk about the what you guys spoke about for each of the questions or things that you found.
So we didn't get through them all, but for changes that will foster the ability to for staff to work at the top of their license with scarce resources. We talked about different shifts, and that 10-hour shifts over 8-hour shifts could possibly facilitate more efficient work. We had a very hard time talking about strategies that don't include hiring additional staff, administrative staff or nursing staff. And one of our group members who works at University of Michigan, they did a time study to document what they were doing that was not at the top of their license, and actually used that to get the appropriate staff.
Oh.
So we're including that as the
idea.
successful model in the next piece, because I think all of us want to work in a place where you can function at the top of your license and have the support of nursing and admin staff to do the things that you really shouldn't be doing at your level of education and pay scale. And then one of our group members, in terms of the second piece, they have a discharge admin. It's an admin level person who is up on the unit responsible for coordinating the discharge piece of things. which I think is a really great addition. And then they also have a social worker who monthly.
This is actually something, I mean, it's EL today, when I told my lecturer I did yesterday, and this girl at their hospital, once a month, the social workers, they all go out to the hub. The social workers pay for an hour of her time to do a 30-minute lecture on burnout. Oh. And how to have work-life balance, and then they do it with your round people and how that improves retention of your grad. So it is
Yeah, so we felt like working in transplant, you need to have support for your staff to address the burnout, which a lot of us don't have. And then we didn't get to the last piece because we were busy talking.
Hi. So for changes that will foster ability for staff to work at the top of their licensure with scarce resource, we thought primarily it came down to education. Some people don't have standard orientation as part of their program, and so we thought using resources like AFON for the pediatric oncology groups would help with that. And then ONS has the biochemo class that people can go through if they're not familiar with oncology and chemo issues prior to hiring. And then now there's the BMT nursing certification through ONS, which may be an option for some people as well that can give them the basic understanding. And then ASBMT lectures on the website would be helpful as well. We also thought for some people, daily in-services and daily rounds would be more helpful, as well as a physician champion. Standardizing rounds. Some institutions don't have people who are available attending-wise to lead rounds, so they use fellows. Role definition, realistic workloads was another piece. For education, we also want to reiterate the use of chat boards and listservs that will help people network and understand what's happening at other institutions and gain ideas that way. And then if you don't have a residency program, sometimes you can steal it from the framework from nursing residencies or medical student residencies. And then successful models for improving workforce recruitment, retention, and work-life balances. We talked a little bit about trying to find time for work-life balances. So that would include realistic workloads. They vary from institution to institution, and networking to know what other people are doing. Also various shifts. There's 8-hour shifts, 10-hour shifts at our institution. That helps with people who have children. They can leave a little bit earlier, and the 10-hour shifters can kind of cover their patients for the rest of their shift. That help them to have a work-life balance. And then, of course, for recruitment, we want to look at empowerment, good morale, education, incentives, and then, of course, financial incentives. Some people have $5 an hour or whatever for certifications, but that's mainly nurses, not so much mid-levels or MPs, PAs. And then we didn't get to improvement projects.
Great, thank you.
At our table, when we were talking about the top of the licensures, one of the issues that came up is that we do a lot of administrative type things that we could get support for, secretarial type support, a lot of letter writing, phone calls, and so on. That if we had some sort of support for that, we could then work more towards what our actual skill level is. And then we thought that one of the things that could be done is by tracking what we do and look at what our NP skills versus non-NP skills, so that would help support perhaps getting some additional administrative type support. So that essentially if we can get some sort of staff to perform tasks that are less clinically oriented. And another issue was to use the EMR that exists at the various hospitals as best as we can, so that in one issue right now they're still, even though they have Epic, they're using paper orders and then transcribing them, so that it's like doing double work. So that's one of the issues, and they're actually looking at that as a project. In terms of balance, we're talking about you working fewer days and maybe longer hours. So in other words, working 10 or 12-hour shifts and fewer days, because what was happening in one institution, they were like kind of switching hours, thinking it's going to decrease the time, maybe coming in later, but found that you're still, working the same amount or even longer hours. And if you can track the time that you're there, some at our institution, even though the NPPAs are salaried, they still clock in and out, so that the supervisor can see what hours they're working. But at our table, in the other institutions, they're not tracking their time, and some of them are flexible where they can, may end up leaving the hospital earlier to go get their kids, but then they're working at home, and that's kind of hard to track your time as well. The other thing is talking about, in terms of burnout, having a combination of things. Sometimes the staff likes to do both inpatient and outpatient, so you get to see both sides of the coin. But on the other hand, there may be some NPs, PAs that don't like to switch, so they have to find what their niche is and what works best for them. When it comes to burnout, also finding a way to get acknowledgement or credit for what you are doing. So I don't know if there's different things in individual institutions to be able to seek that out. For new grads that are wanting jobs, from what our table discussion is that you've got a lot of nurses that are going back for their NPs, doing it online and so on, so that they have a pool maybe that they can pull from when they're looking for an NP within the HEMONC BMT setting. But if you have somebody who's new and doesn't have that background and maybe now wants to get into it, you don't know how dedicated they're going to be and if they're going to have that burnout, so that's something that has to be looked at. Another issue that came up in terms of the practice aspect of things was also if you're restricted because you may be a PNP degree, you can't work in an adult setting. So depending on how that's structured in your hospital, that could be a problem. And then even now, I understand that there's issues in some states where, depending on the type of licensure you have or your degree is for an FNP, perhaps if you're in an acute setting, you may not be able to practice in all types of settings. So one of the things was to see what you could do in terms of also quantifying your time so that you can justify what's being done. In terms of projects that are being done, there's a throughput project that is being looked at in terms of how to move patients from one spot to another, and that's being done through a committee, and the quality improvement manager is the one that is kind of heading that up. And then another project at one of the hospitals was talking about the preparative regimen being on paper and looking at how much time they're spending, then transcribing it into Epic, and then now they're going to be getting it loaded into Epic up front, so then they'll be able to compare the amount of time that's going to be saved.
Thank you.
So our group talked with what changes will foster the ability for staff to work at the top of their licensure. I think one of the big things that came out of the discussion that hadn't been mentioned from the other roundtables were at UF, Health, University of Florida Health, a lot of our PAs have a lot of autonomy where they can do procedures and things like this without the direct supervision of the attending being there. And that's really helped with their, satisfaction at work and things like that, where you don't always have to pull the attending in to go and watch you do things, that you can have that level of security, that your attendings and the facility can have that level of security with you to give you the autonomy to act on your own. We also discussed involving the mid-levels in quality management and scheduling non-clinical time with educational videos and having breakout sessions for education, and where the education is easily accessible and easily tracked for fact purposes and things like this. For the successful models for improving workforce recruitment, again, we talked about the internships and things like that, like a lot of the roundtables did. Scheduling flexibility, things to be a reoccurring thread through everyone, having the time off to do things and having set 10-hour shifts so you have that day off. But like at our institution, they're already doing the 10-hour shifts and they're salaried, and so they're not getting that extra day off. But to be able to do that, to recoup and to spend time, with your family and stuff is important. And we didn't get to the last one either.
Okay.
So.
Thanks. And something that we were talking about, one of the centers has 24-hour coverage by PAs and NPs, which sounds wonderful because at our institution on the weekends, it's a PA and a moonlighter who a lot of times doesn't know anything about transplants. So Monday morning, you pick up a list that hasn't been updated in a couple days. So that sounds like a wonderful model. Although I know for our group it might be hard to find PAs and NPs that want to work overnights, but I think that it's something to look into. Paula, did you?
We don't have a lot of changes compared to everyone else either. So in the first one, we thought having some standardization or some clinical practice protocols, so you're not always going back to the doctor to verify that that's what they want, depending on how many doctors you work with. And that would free up some of your time, too, to be able to do more procedures or other things. With the work recruitment, retention, and work-life balance, some of them are doing the 10-hour shifts like you guys are doing in 12 hours, but they're not really getting the time off either. So I think my opinion on that is you're not having the right staff there. Maybe you need to up the nurses or something else, so you're not doing that kind of work. And then clinical practice improvement projects. One of them is working on a hypertension line streamlined. I don't really get all that yet. But and then treatment planning visits, and then the summary visits for survivorship. And that's about it.
Okay, great, thank you.
And then we're at the back table there. Basically, I think that, in summary, from what we discussed back there was, in order to try to work at the top of our license, it would be good if we could find other people to do things like disability forms, prior authorizations, such as social work, doing less clerical work. The other thing was, again, rotating inpatient, outpatient to try to prevent job burnout and get caught up on your work. There was mention of when you're inpatient, you've got so many discharge summaries to get caught up on. When you go to the outpatient setting, you sometimes have a little more downtime, able to get those things done. We talked about an administrative day to be able to do some research. again, to try to either work at the top of our license or for better job satisfaction. And then getting your credentialing paperwork, all these other things that we're expected to have updated within our institutions and with the state, have time to get all that completed. We talked about self-scheduling, so instead of having the chief person at your institution doing just scheduling, just the group of you getting together and being able to cover the gaps, fill in each day. And we talked about to retain and recruit, having good training programs in place for your new hires, so that they're able to feel comfortable working independently. And I think that's about it. We really didn't have any QI projects that we discussed. Nothing was really going on a whole lot. So I think that's it. If you could, does anybody have any questions or other comments? I know you had mentioned, somebody over there I think had mentioned about the session about the job burnout. Dr. Burns had given a talk yesterday about job burnout in physicians, and it was an excellent talk. There's a survey that I think I might take back to my group, just to get some feedback. I can't remember. I think I had it written down somewhere, but it's a survey. You can find it online, and I can't remember the name of the person. There's a name associated with it, but it looked interesting. So I think just for fun, I'll take that back and see what kind of feedback we can get from our group to try to improve things. So if everyone could just leave the papers at the tables on the way out, I'll collect them, and then I'll sort of summarize everything and get it out. And if there's any, we could have some further discussion on the listserv, different ideas that people may have throughout the country. That'd be great. So this pretty much concludes our session this year. I think we had a great 2 days, a lot of excellent speakers, excellent topics, and we're going to go ahead and do it again next year. Hope that you can attend. Karina and Melissa, a question? We did. We talked about that. Yeah, we talked about that at our meeting last night. We're going to try and do, we have some things that we've thrown around. We'd like to do maybe Friday and Saturday. Maybe just keep it on one day only and do 2 tracks to include some basics for new people that are in the field, and maybe to include some pediatrics. So there's definitely room for improvement. We always have a learning curve, and so when you're filling out your surveys, go ahead and put all those suggestions in there. We'll get them for next year's meeting and continue to try and make some improvements. I think that's a great point to bring up. I want to thank Paula again she's our outgoing chair, and I think she's done an excellent job the past couple of years in growing our SIG and making it what we are today. So thanks, Paula. And we have a lot of great people on board with the steering committee, so there's a lot of enthusiasm, and I think we're going to work together really, really well this year as a team to continue to promote our SIG and get some good things out there for us. And like I said, feel free to get onto the ASBMT website, join ASBMT, become a member of the SIG. If you want to get involved, there's lots of areas to do that, so feel free to contact me. My email's on there. Paula's still on there. And I think our steering committee's emails are on there too, so feel free to contact us. And we hope to see you at the regional meeting in October. If any of you are able to get to Boston, it's a weekend meeting, 2-day meeting, and I think there'll be a lot of good topics there as well. So thanks again. Have a safe trip home.